Hi, everybody. We're going to talk about the neurologic PT evaluation in this lecture. I am going to break it into a few lectures because it's quite long. And you might say, why or how am I going to complete this 100-slide lecture evaluation in the time slot that I'm allotted for a patient? This lecture is really comprehensive. It covers kind of everything you would need to look at for the most part, except for a true vestibular evaluation for a neurologic patient. And what we'll talk about more in class and we'll spend some time on in class is how do I pick and choose? What's important for a specific patient? What's important for a specific evaluation situation? You'll also find that there's a really large cognitive component to this evaluation, and you might be wondering, like, I'm not a speech therapist. Why would I maybe spend some time there? And so we'll talk about each of these as we go through. Again, not every patient you see is going to need that full cognitive evaluation, but you might be the person who needs to do a cognitive assessment. You might have a Parkinson's patient who is having some cognitive changes, or you want to screen them early on so that you can tell if they've had cognitive changes as you follow them up. You might have a new onset stroke patient or a new traumatic brain injury patient. And really understanding their cognitive load is going to help you determine your treatment interventions and help you really to guide your PT evaluation a little bit better. So we are going to spend quite a bit of time in some of those areas as well. There are embedded videos and embedded links in the PowerPoint to show you most of the skills that we're going to talk about. I am not going to click on them and play them in my lecture or in my recording because that'll just take extra space and time. So you may find that you want to pause my talking if there's a video that pops up, be able to play that video on your own screen and then move forward. That way those videos are embedded the way that you can click and play as many times as you want to see what you need to see in that situation. So overall objectives, I really want you to understand what are all the pieces and parts that go into a neurologic evaluation. There's also a lot of scales and test scores that we'll cover in this eval, and I'll try to make it really clear, but almost all of them covered in this are going to be numbers that you're going to need to know both for this class as well as you prepare for the board exam. So the neurologic evaluation can be really difficult in terms of scope to get really a handle on what am I evaluating, how am I prioritizing, how am I spending my time. You might be asked to screen a patient, for example, following a concussion to see if they have any neurologic sequelae. You might be seeing a patient in an acute care environment who had a fall and they want you to screen if there's any lasting neurologic symptoms or effects. Or you might be evaluating somebody with a really significant neurologic infarct, a severe stroke, a severe brain injury. And so you have really high functioning patients and then you have really low functioning patients that you're encompassing in this huge spectrum of the neurologic evaluation. You also have children as well as, 90-year-olds that you're encompassing in this same evaluation. And so it gets a little tricky. Think about in the orthopedic world, you have a little direction right out of the gate, right? Most of the time they come to you for back pain. And so you start your evaluation, for example, in the back. Now, it might lead you down a path to look at their hips or their knees or their shoulders or other parts of their body. But, you can start, you have a starting point. A neurologic evaluation is very much the same, only you don't have a body part that's really what is guiding you. You kind of have a pattern of symptoms and a pattern of presentations that's going to help to guide you a little bit more along the way. You may have patients who come to you with a diagnosis. So patient comes to you with a left CVA is going to give you a little guidance to your evaluation. But you might also have a patient who comes to you with diffuse neurologic changes or falls. And as you're teasing out your neurologic eval, you're starting to try and figure out why is this patient falling or what's happening and really using your differential diagnosis skills. Having a strong neuroanatomy background is really going to help you with this because you're really going to be able to tie in, okay, they're having coordination issues. Maybe I need to look at cerebellar testing or things like that. And often you may have kind of a game plan at the beginning of your treatment, but then as you're starting to do assessments and examinations, you might say, I have some subtle findings here. Maybe I want to jump down that rabbit hole and follow this for a little bit. So it's very hypothesis guided in terms of the evaluation. And we're going to talk about some tools in class that'll really help us to focus this. But just know this whole lecture is kind of most of the bags of tricks that you're going to need. So these parts are pretty familiar with any patient evaluation that you're going to do. You know, a thorough chart review, a thorough review of medications. A lot of neurologic signs and symptoms often overlap with medication side effects. So it is really important to take a peek. You know, if somebody's dizzy, if they're lightheaded, if they're having issues with their blood pressure dropping, is that tied to the neurologic condition, or is that possibly tied to some of the other medications that they're on as well? We're really going to want to look at precautions and limitations that this patient may have. And so getting a really solid history is really going to help us understand what's going on. Know that in the neurologic world, you know, your patient may have had a really significant life-changing event, or their life is starting to change because they've got a degenerative condition. So really important things as the clinician is you need to be really open and receptive. You'll find your patients have a lot of things to bring to the table and a lot of really interesting questions that maybe you weren't prepared for. Making that patient really comfortable with you, and then being able to try and guide your subjective. You know, I could spend a half an hour getting a good neurologic subjective, but how do I make that timely and efficient? You know, one tool I use is to get kind of the basics I need to get moving, like past medical history, that kind of stuff. And then I'm asking other questions while I'm conducting the evaluation, whether it's of a caregiver or whether it's of the patient themselves. You know, while I'm looking at range of motion, tell me about your home life. How are those kind of things? So sometimes you find tricks and tips that can help you get a little more effective in your time management there as well. A chart review, obviously, for those of you working in an acute environment, in an inpatient rehab setting, this is really simple and easy. It's accessible to you. If you work in a hospital-based, even outpatient facility with electronic charting anymore, these things are a lot easier to come by. Those of you in skilled nursing facilities, those of you in like more privately owned outpatient clinics are going to have a little trickier time getting these pieces of information. So really important things to look for. So diagnosis, very often, especially in the outpatient world, we'll get a script that says CVA. Thank you, sir. That's very helpful. You know, trying to delve, can I get a more specific diagnosis, whether from the chart review, whether from other pieces and parts I put together. You know, if somebody has a left anterior cerebral artery stroke, that's a lot more descriptive than stroke. Or if they had a frontal parietal subdural hematoma, that's a lot more descriptive than traumatic brain injury. It really helps to guide me a little bit more as to what I need to evaluate, what I need to spend a little more time for. PT orders, obviously, in a lot of your states, you may have direct access. You may or may not need PT orders. But I always bring this up and something to think about from all my acute care time. You know, you have PT orders. What are they for? And are those things appropriate? So do you have PT orders to evaluate a patient who is unsafe to mobilize and they want you to mobilize that? Or on the flip, do you have PT orders but then the patient's on bed rest inappropriately, that there's no medical reason that that patient should still be on bed rest? So here comes the trick of, you know, clinical decision making, critical thinking, problem solving. Is what's being prescribed appropriate, or is there, you know, cause to call the physician and say, hey, did you mean to leave in bedside, or did you mean to leave in bed rest orders for this patient? Can't tell you how many times I've called and they're like, oh no, they should have been off of that days ago. We just forgot to clean it out of the computer. Or, oh, let me ask the head physician. Oh, sure, go ahead. Or those kind of things. So it's always worth asking. Cautions and precautions. So things you may find, are they a falls risk? Has there been a documented fall? Is there a neurologic reason, for example, head of bed to 30 degrees? So you might have a patient who has a drain in place or different things for their neurologic intervention, especially in the acute care or critical care environment, that they may not be able to be flat for some reason. Do they need assistance when they're up? Are they on bed rest? Do they have weight-bearing precautions? And again, are those things appropriate? Are they specific enough for what you need to cover you, but also to allow you? Things to think about medically, and we'll talk about this with each of our conditions. But, if they came in for a stroke and they had TPA, which is a drug to break up the clot, administered, often there's a hold time by facility policy for how long they can be mobilized. Currently it's 24 hours, but I've seen shorter intervals depending on where you are. What is their INR? What is their partial thromboplastin time? Are they too high? Are they unsafe to mobilize them because their lab values are out of whack? Some of those kind of things are things that you might find in those situations. So I want you to brainstorm, take a couple minutes and try and write down as many subjective history things you can think of. We'll talk about some of the areas over the next couple slides, but I really want you to see how long of a list you can come up with and how detailed you might want to get in some of these instances. We're going to spend a little time chatting about this in class just to make sure we can get a really solid subjective on these patients. If you need to pause to finish your 2 minutes, great. If not, we're going to move forward. So history of present illness, we have things like date of insult. Now this is one we may or may not have, depending on the pathophysiology of what is going on with your patient. So your patients with stroke, with traumatic brain injury, are going to have an insult date. They're going to have, on June 5th, I was in a motor vehicle accident, or on, this day I started having symptoms and this is when I was diagnosed with a stroke. You have another whole set of neurologic conditions where maybe they're more progressive in nature. They have slow, subtle changes in signs and symptoms. And you may also have patients who are undiagnosed, who have a set of symptoms, but we don't yet have a diagnosis to go with them. And you might be evaluating any of these. So for example, your patients with Parkinson's, Duchenne muscular dystrophy, even cerebral palsy, you might have to really ask a lot of questions about, so when did your symptoms begin? When were you actually diagnosed? Talk to me about the progression of symptoms that you've had over that time frame. And another one I even like to ask is so talk to me about the past 6 months. What are things you could do 6 months ago that maybe you can't do today? Or if they've mentioned a time frame somewhere in their evaluation, talk to me about what you could do before that last month versus now. For example, your MS patients might have a relapsing, remitting presentation, and so you might want to say, at your worst, what have you been, and now, where are we at today? Is today relapse, or is today pretty good that you're in front of me? Obviously, if they're in acute care, signs and symptoms prior to the admission, as well as since the onset of the admission. And then, what interventions have been done for this patient? So what medical imaging was run? What treatments have they had? If they had an aneurysm, were coils placed? If they had a hematoma, was it evacuated or did they wait for it to reabsorb? Did they put in a drain? What medications has the patient been put on? Have they been put on anticoagulants? Have they had surgical procedures to manage this medical condition? And then other sequelae post. So for example, if they're a brain injury, they may have been in a car accident. Did they also have any orthopedic issues going along with it? Have they had ablations of their brain? Have they had craniotomies? There's all kinds of, have they had parts of the brain removed or resected as a result of this? And this really helps to gauge your medical status, kind of know how stable they are, what some of your expectations might be. You may also want to look at, what outpatient treatment have you had? What time have you spent in an inpatient rehab facility versus a skilled nursing facility? How long ago was that? What did they do? What did they work on? Those kind of things, because a lot of these patients may be in for multiple rounds of things. So, you might not be the first time they're coming to a rehab facility. And it's always nice to know what expectations those patients come into you with.